So now we'll have our panelists come up to the microphones here. So thanks so much to our panelists for their great comments. So you'll notice for questions, we have students in the aisles with microphones. So if you do have a question, please raise your hand and we'll have a student come over and give you a mic. But in the meantime, while you're stewing over the various questions, I wanted to kick us off a little bit. And I was hoping our three panelists could weigh in on if they have seen changes post-implementation of the Affordable Care Act in terms of the appetite or adoption for technology and innovation, and depending on their answer, what is the core barrier or core helper to those sorts of trends. So I'm not sure if anyone wants to start or if you want me to call on someone. Neil looks excited, so I'll go.
I guess you decide to call on people. First of all, there's a couple things that have happened. 12 years ago, people didn't know that technology could do some of the things that we wanted them to do, and so you had to convince them that technology made sense. You don't have to do that anymore. I think that's clearly obvious from our daily lives that technology, whether internet, cell phone, and others, has ways of doing some extraordinarily important things. We used to have to convince people that you could actually save money by preventing a condition and by preventing the progression of those conditions. I think everyone recognized that the very, very sick, congestive heart failure, readmission rates, that if you did certain things, you could save money. But getting people to recognize that the group beneath that, not the very, very, very sick, but the ones who are going to become sick, has been an important population. I think that's changed. I think people are recognizing it. Many organizations don't have the bandwidth to approach it, or they don't think they do. And so that has been a major change. I think that the final one really has to do with how people want to pay for things. When we started, most people paid the health plan, the provider, the employer, for the individual seat, for the session, for the workshop, for the lesson, similar to a fee-for-service model. I think more and more people are going to want to pay for performance, where the individual providing the service will be at risk for outcomes. By the way, we're fine with that, because we think our outcomes are great. But the bottom line is that that will change, because that's much more in line with a value-based payment structure rather than a fee-for-service.
So, I think that in terms of thinking about, how the ACA has really, I guess, shifted the conversation, there are a couple of things that I think are good to note that sort of dovetail with what Neil just mentioned. I think that the first one gets back to something that Dylan mentioned initially, is that, one of the big things about the ACA is that it has improved access overall for individuals, but with increased access doesn't necessarily mean realized access. And in terms of actually being able to provide healthcare for everyone, we need to figure out how are we going to actually provide care for all these individuals who now have more accessibility in some ways in a necessary but not sufficient way. And so I think that with these new type of technologies, it does provide us the option to really reach out to these individuals in ways that will expand the way that we can deliver and ensure their health. I think that the second thing is that the movement more towards population management and population health from the ACA is probably the other thing that I think has really spurred on interest in terms of the technology. So of course, as the technology has progressively changed over time so that we can do a lot more things, I think that, again, now that we have the, increasingly focused much more on delivering care to a population and trying to care for individuals in ways that are outside of the clinic walls so that we can make sure that they are healthy overall, are things that the technology can really help us with. And so I do think that the ACA has really moved that conversation forward, and now we just have to figure out the right ways to deliver it.
I think I would say that when we talk about the ACA doing things, certainly it brought more folks into the possibility of access, which is a big deal. But in terms of exactly what they have access to, although the 30,000-foot view is now pretty clear in a lot of ways and reasonably similar, when you get down to the details, which tests, which treatments, which services, does it support the sorts of more sophisticated digital access that we're talking about here, there's just a lot of variation, and the ACA is not as explicit about these things as many people would have wanted it to be, nor necessarily as relevant. EHBs come up on a frequent basis where we talk about essential health benefits, but Dylan, given the small group market and the individual market in California, that's not that huge a percentage of Californians. Still, the vast majority are either in Medicare, Medicaid, or the large group markets, and EHBs are not at least the versions of them that we speak about are not relevant for those. And even within that frame, the HBs are not specific. As the example that I was talking about, exactly which form of mammography is or is not. These are things that are not clear, and I think we're going to have to roll forward. I think one of the big hopes is that the digital information will become clearer about what is happening for who, or at least, and this is something that would be very nice, an all-payer claims database. Although that's just claims, it's not the kind of detailed information on outcomes or anything else we really want. That would be a good step, and California has not yet done that yet. And that's a long process too. I believe Massachusetts is still working on rolling theirs out, but that would be a step towards knowing not only that we have everyone within the insurance world, but beginning to get at least a gross idea of what is being provided to them on what sort of basis for how much.
All right, thank you. So do you have any questions from the audience? So can I ask you to share your name as well as your affiliation with UCLA or your organization?
Hi, Richard Singerman, I'm adjunct faculty at Hopkins. I've covered this event for about a year and a half. I spoke here about a year and a half ago. So really two questions, they're both pretty different. One is the new role of the FDA. On one hand, people look at the FDA as a barrier, but on the other hand, if you pass muster, then it's great branding. So I'm wondering, with all these digital helping tools that are out there from A to Z, what do you see as the yin and the yang of the FDA? That's one question. And then the other one is, I was just actually speaking with Paul Vignano, who spoke here last month, CEO of Children's Hospital, and he mentioned that now 75% of their population is on Medi-Cal. And so I'm wondering, where are these new wellness technologies fitting in with these providers that were very fee-for-service oriented in the past and are now changing? Is it that they're becoming part of the risk models, or the technology is helping with the 30-day lowering of the recidivation rate, or these kind of things?
So I'm happy to take a stab. So I think that in terms of both the questions that you raised, I think that with the Food and Drug Administration, I think that it is something that increasingly people in the digital space are finally coming to realize that they can't do technology the way that they've done in Silicon Valley and just put something out there and people will buy it. That they actually need to demonstrate some type of benefit, and increasingly, while the Food and Drug Administration hasn't really gone to that same framework in terms of how we might look at pharmaceutical drugs, at some point, given the frameworks that they work with, there's certainly a good possibility that they may end up in that framework where they are going to not only look for safety but also for effectiveness. And if that's the case, then that will really change how innovation happens in the digital space, whether it's with software applications or again also with hardware applications too, because there's a lot of that's also happening with these new technologies. I think that in terms of the movement towards more risk-based models and more capitation type of agreements, I think that will again also encourage providers or provider groups to really look at new technologies that potentially can minimize costs and still deliver effective care. I think that people will not always necessarily look for showing that it's better, but they may look for making sure that it's equivalent as long as it can reduce costs. I think that the big thing though is that there's certainly a lot of interest in these technologies, but actually demonstrating what they actually do, how effective they are, who they are effective for, because I think that, as we might all imagine, there's no one-size-fits-all for different types of technologies. And as Neil was mentioning, some patients will really respond better to having a face-to-face encounter with their provider. Other people may feel much more comfortable doing it digitally, and I think that we just need to figure out what's going to work best for the different kinds of patients.
Echoing the notion that if the FDA has the ability to move more from pure safety to effect, and even one can dream of the idea of them recommending that certain things not be done. Although that is iffy. The United States Preventive Services Task Force actually does recommend a few things not be done, and that is not considered very strongly within the payment world, or perhaps even by some of the providers. I think we are still within the world of to do, but not to not do. that also might be another question of where we might need to go next with quite a number of different test treatments and services. And we have some basis. The AHRQ, USPSTF, some other things are trying to roll out in that direction, and we'll see where they can go over time, and whether or not something like the FDA can do something. But I would point out the political aspect of this. The Affordable Care Act very explicitly talks about looking at what USPSTF says, except around breast cancer, and it froze the recommendation to an old one and said, ignore whatever they say from this point onwards. And I think that political aspect of what is or is not done is going to be consistently important.
So I think the question you ask is much broader than the FDA. Yes, the FDA is important for certain elements. Many of the digital therapeutic activities are medical device, if you're managing someone's blood sugar and giving them advice, but many of them are not considered medical treatments, so that they are outside of the FDA. But that doesn't mean they're completely unregulated. I think a good example is the CDC over the last years had decided that it wanted to bring the diabetes prevention program to the masses, and decided to do it using groups rather than the individual one-on-one the way it was originally created and published in 2002. So that was very good. It was successful, and the YMCA and others have done that, and major studies have come out of it that demonstrate that it still is effective and saves money. So much so that the Secretary of HHS announced that Medicare fee-for-service, we expect, will be paying for that service. However, who can deliver it? Under what circumstances? How do you make sure it's faithful to the original model? How much do you get paid for it? Is it payment based on results? Most likely. Can digital programs be covered? Probably, but you're not sure. The CDC has recognized programs, including digital programs, about a year ago, began recognizing those programs. What does that mean? Is CMS going to accept the regulation or the recognition that the CDC says? Maybe not. They may want more. So I think it's really going to get to be a very messy and challenging thing, far beyond the FDA as the only one, because it clearly enters into so many other domains. And we know that the bottom line still is, will somebody pay for it? Regulating it is one way, but paying is the ultimate question. In terms of the changes in risk base, I think what I would predict we're going to see is increasingly companies that you don't think of as risk-bearing will take risk through episodes of care. So take, for example, diabetes, take chronic kidney disease, take conditions that require a lot of self-management, but also a lot of medical treatment and a lot of visits to the doctor and a lot of technology that's helping you to do that. Are we going to see a partnership between UCLA, as an example, and companies that create some of these materials, devices, et cetera, that a 1 year in the episode of care for that individual? Now, we're doing episodes of care for hip and knee replacement. That's pretty not straightforward, but it's a lot more straightforward, though the patient's behavior does make a huge difference around rehab, but that's infinitely smaller than is a person with chronic kidney disease going to get better, or diabetes, et cetera. So I see that as things go more toward risk-based and risk-bearing, we're going to have very interesting changes in the companies out there, whether they're pharma companies or others, who will figure out how to take risk along with partners, and those are the ones that will probably succeed.
So I had a follow-up question, actually. So, well, we have a question down here, but let me ask can I get a mic up in the front? So I had a follow-up question before we get the next question. Mike, you had mentioned telehealth and the UCLA system. We have seen these options like MD Live and Teladoc, and it seems like there are technology services being delivered through insurance companies, through consumers paying out of their own pocket. And how do you all view that as conflicting or being built into physician involvement? And does it create problems, or does this actually help us move the use of technology along and address healthcare needs?
So, I do think that those type of technologies are beneficial for individuals, but I think that it depends on the actual use case scenarios. So for a lot of these products that are more urgent care oriented, if you were otherwise a pretty young, healthy individual and you happen to have an upper respiratory infection and you just wanted to, get a better sense of what should you do, calling up one of these service lines, they'll walk you through their algorithm to make sure that you get what they would consider appropriate care. That being said, not every patient's going to fit that situation. situation. So somebody who has more complicated health conditions or a number of chronic conditions, that might not necessarily be the best person to turn to. And the other thing is that as you think about that particular individual with more conditions, you probably want somebody who has access to your health records so that they can actually review and make sure that the recommendations would be appropriate for your particular health situation. And while we do have ways of sharing that information across different types of providers, that's still pretty early on at this point. And that's not something that's happening. So I think that at this point, from at least our delivery systems perspective, it is something that we have been looking at and partnering with organizations to deliver those services. I think that it is something that would be useful, but it's not, for an entire population that we're managing, going to be the entire solution. So those type of companies may not necessarily be able to provide the breadth of care that we can. So that's part of the reason why we have to figure out how to make sure our providers who are specialists in their fields are also going to be able to deliver care in addition to these companies that are already delivering urgent care basis.
Okay.
I think you've used an example that's hitting on a much broader question, and that is, you could call it a battle, you could call it competition between direct-to-consumer and clinician-inspired, clinician-managed. And we've always had direct-to-consumer things, over-the-counter medications, you didn't have to see your doctor, a whole lot of things. But now we're going further and further into treatments, therapeutics, blood testing, as you mentioned, direct therapies, et cetera. And the question becomes, are we going to have systems where individuals are going to receive those things in the context of a therapeutic relationship, even if it's not that relationship with their individual clinician, but within their team, so that does the healthcare system have a white-labeled telemedicine, which 24/7 gets them to somebody who still calls up and answers the phone, this is UCLA on your behalf, and it can look at all the records? Or is it going to be direct-to-consumer, the equivalent of a Minute Clinic or a Ready Clinic or a commercial clinic, that may or may not be linked? And I think that's going to happen at every level of healthcare, where we're going to get more and more and more direct-to-consumer, effective things that may or may not be regulated, and they need to be, as we've learned from Therasis, et cetera, that are going to be in competition with providers. Does that mean that providers will become obsolete? That's an extreme statement there, because when I have my heart attack, I hope I never have one. When I have my heart attack, I certainly want that person to know what to do. But to prevent my heart attack and all those other things, maybe I don't need the doctor. I still do, but it's a very schizophrenogenic way of thinking, if there is such a word.
You just started it. John, did you have a comment?
Just the one more piece to add within that frame of as we're talking about telemedicine and the other pieces, I think the physical location is going to be an interesting piece as well, since we are used to talking about the concentration of urban populations where there is physical locality somewhere nearby, and telemedicine is done in concert with that backup, with those options. But there are fairly good chunks of our country that have long distances to go, and the idea of being able to get to even an urgent care center is not entirely realistic. I think it's going to be interesting and possibly a great room for growth, because it is the difference between something and nothing. But what if it is the difference between partial? What if it is not the kind of thing that the Department of Managed Healthcare would license an HMO to, because you're simply physically not close enough to large numbers of the services you're supposed to be able to get? I think that will be interesting to see how that rolls out in the near future.
I think so. Yes.
John, my name's John Myers, graduate of law school and health lawyer. And I guess the question I have for all of you is there a single technology that you could identify that would have the effect, if paid for properly, to actually reduce aggregate healthcare costs?
Last part of the sentence, that was.
Well, to see, is there a technology that you can identify that would have some effect? You were the guy who could implement it and say, if everybody did this, here would be a significant material aggregate effect on aggregate healthcare costs. The costs would be reduced by the implementation of this technology. Do each of you have something in mind, I guess, is the question. Is there something that's, but for something, if you did it now, you could save lives, you could save costs?
Here's one that's not super sexy and technological, but the studies keep saying that having a nurse visit the child for the first, I think it's 3 months,
Actually, the study's prenatal to the first year of life. It modifies their outcomes as well as prevents child abuse, if that's what you're referring to.
Right. It does remarkable things to the success of long-term health, and it's
Family nurse partnership.
and it's been known for quite a while, but the payment models have not been done properly.
If you ask me, I got to define a couple words: ecological momentary assessment and ecological momentary intervention. Ecological momentary assessment says that an assessment occurs within the context in which that person lives in that moment. Ecological momentary assessment. And intervention says that within that assessment moment, something happens that helps that person to change their behavior. So there are technologies, smart technologies that are being developed, not yet ready for prime time, not in our company, by the way, that look at how do you take the range of information that is being generated from all these wearables, which I think just help you run your 10K faster, doesn't improve your health yet. But how do you take that information and enrich it with environmental information about temperature and other things, and then help that individual to make a better micro decision. Micro decision is a tiny little decision that doesn't really mean much by itself. Any micro decision you make that's bad is okay, but the sum of them determine your outcome. So you're really getting at the individual's behavior at its core, sort of granular level, and allowing them to get assessment in some way, then have some information, some kind of intervention, some kind of support that helps them to change their behavior.
Yeah, I think my answer is sort of similar to Neil's. I mean, there are so many things that we know matter from healthy behaviors that people don't do. And if we were able to implement a technology to encourage people to do the right type of healthy behaviors, whether not to smoke or take up smoking, to do physical activity so we minimize obesity and other types of cardiovascular conditions that go along with that, eat appropriately. Well, even when we give the gym membership, people don't necessarily. I have a gym membership. I'm not going to tell you how frequently I go, but I do think that some kind of thing that would actually encourage people to do the right kind of behaviors. We know those things. We know what we should be doing, but we're still not doing them.
So we have a question up here.
Because physicians are taking care of patients without taking a history, all kinds of inappropriate things are done. They're, I think, staggeringly waste. And so if you're going to fix the most basic problem in medicine, we got to give physicians an adequate history before they start doing stuff. There's technology available, patient self-assessment systems. I've been working on one for decades. Works beautifully. It changes decision making. So at least I would propose that's one thing we could do to help physicians do what they should be doing and yet don't do. And as a process, they miss the symptom patterns, they miss the big picture, and they make horrendous errors. Our system has kept patients out of the operating room when they never should have been referred to surgery because no one took a history. So that's at least would be my suggestion.
So,
Hi, my name is Lori Brazell. I'm an author and independent researcher. One of the phrases I haven't heard anybody use is preventative medicine and personalized medicine. And so in answer to the gentleman, the lawyer's question about what would be one of the great technologies, there's a lot of information that's now available through genetics and genetics testing. How do we move the healthcare and insurance industry from a response mechanism to a prevention mechanism where they're willing to pay for prevention when you know that a person is risk positive? It's easy to talk about BRCA and about breast cancer, but when you start talking about dementia or plenty of other things where you have evidence that in a family, how do you get the insurance industry to pay for a patient to go to see a geriatric geriatric neuropsychiatrist to assess that patient's risk when they are at midlife rather than waiting until they've already started having symptoms?
The way I answer that would be two things, if I can remember the second. I think that we will get there, that the genetic predictive capacity, unfortunately, for most things, doesn't predict a single condition like breast cancer that a mastectomy could prevent. They're going to be much more multifactorial. They're going to be they're not going to be single genes. They're not going to be a condition that has a treatment or a method that can prevent that particular condition for a while. I think we may get there quicker than I think it was. I would have said 30 years, maybe it'll be 15. So I don't think we're there yet. And I think that a better way to think about it is personalized medicine, to me, is not only based on your genetics. It's really based on your characteristics. And those characteristics are a range of characteristics: age, ethnicity, gender, socioeconomic status, where you live, social determinants of health, a whole series of things about you. How you like to learn, how you want to get information, what excites you, what bores you, what would get you to try something. Do you like to do things through a game? Do you want to do things through other methods? And so if you think about a preventive approach where you're able to segment populations very finely using big data that has you to understand what's that individual's characteristics, what makes them more likely to respond to this or that kind of a treatment that's a preventive treatment or a medical diagnostic specific treatment that helps them to change their behavior, helps them to get the medicine that they need or to do something else, but it's personalized. I think that's the revolution that's going to happen well before the genetics of prediction of treatable or preventable conditions occurs. I think you have to think about what a public good is versus a private good, and the reason that single payer systems or programs that put everyone into the same risk pool can think about that is because it's a public good. When you have a system where individuals are part of individual insurance plans and we have the complete choice of changing every year or 2 years or 3 years, you're going to get the behavior of those organizations for their own survival that's not going to think about 10 or 15 or 20 year changes. That's just not the nature of any of the businesses that we're talking about. So you have to have a public will that changes that. If you look at the federal employees, for example, most federal employees stay as federal employees for a long time. They may move between branches or businesses, but on average compared to others. So the federal employee health benefit program cares about their employees no matter where they get their health insurance. And they tell all the health insurance providers sort of to do the same thing. So you've now gotten almost to a fixed population that's stable enough, stays long enough that the employer cares about. The same thing could happen in Medicare and other programs where you've got a fixed population. Without that, I don't see it happening at any great scale until consumers demand it. And that may be the other side of it. As you look at the personalized medicine side, consumers will demand more of that, and then their employers and insurance and providers will provide it.
It's also problematic that Medicare itself, that most of the long-term interests that you're speaking of, that can be long-term, the insurance companies themselves don't have those people after age 65 when so much of what we're interested in those longer-term pieces becomes an issue. So it's not just churn during the period in which they're seeing different people every year, but at some point those people quit being part of their population, and that also limits that event horizon for them.
Daniel Parlins, resident physician here in internal medicine, primary care. So going back to barriers and incentives, say you wake up tomorrow with the most incredible dream for a digital health company that is guaranteed to do the things you guys are talking about: decrease costs, improve health outcomes. What would be the very first problems you would seek to solve before going to market and pursuing your dream?
You're asking Neil to give away his next business idea.
Boy.
I don't know if I really have an answer. I think that in terms of the problems that we want to solve, I think get back to are we going to be able to change people's trajectories and keep them healthy and keep them from doing things that will lead them to ill health? And so whether it comes down to their genetic predispositions, which again, I agree with Neil, we're not exactly there yet, but we know that there's a lot of social behaviors that interplay with the underlying genetics. And so if we can personalize the right type of messages to get to people so that they'll stay on track, I think that would be what we would like to do, regardless of what their underlying problem is.
I think my answer would be it depends on what your motivation is. If your motivation is to make money and to make a lot of money, you've got to figure out who's going to pay for it and where you see 5 years from now the payment structure going to be there to cover this great invention that you want to sell for billions of dollars. If on the other side you want to impact the most lives and have a business that's viable, which is very different than creating a unicorn, so to speak, you're going to focus on much more mundane kinds of challenges and problems. And if you look at those problems, really differ by age segment. So in the preconception, prenatal, and early childhood period, you'd address one thing. In the school age, the whole life course differences. And so you have multiple different criteria that you would use to make it so that your company would make sense. The final answer is, if it's really you, it's what do you want to do? What are you passionate about? What are you going to have fun doing? Because you shouldn't waste your time on things that aren't fun to you.
And to some extent, maybe if we could just properly use what we've already got. And I would give as a good example for the histories that were mentioned, at least in my own case, my physician has gotten really good. There's this nice screen that she can turn around and face at me, and it has every weight she's ever done on me, and she shows me the graph and goes, "What are we going to do about this?" And then sits there with this terrible silence. I think that's very effective use of technology. But it does mean she's got to motivate me. She's got to get me to change. And that's a start.
I really think that we're focusing too much on technology as the answer. I mean, technology is an enabler. What we really need to focus on is having the patient really own their health. I mean, the industry is going to naturally move from volume to value. But what we're forgetting here, to your point, Neil, is the patient itself. I mean, self-management is critical, but you have to remove the barriers that keep people away from adhering to their, treatment plans and so forth. I mean, I think that's really, to this guy's point. I mean, it's not inventing the most technology or the best technology or the best business model. It's about getting the patient to adhere to their treatment. You don't need technology for that.
Technology, when it becomes the star of the show, invariably doesn't work and sets up dynamics that aren't sustainable or appropriate. Whereas if technology enables what the individual, whether it's the clinician, the patient, the consumer, wants and needs, you're much more likely to have something that makes sense. And just because this is public health, we have to have an advertisement for making the healthy choice the easy choice, which has nothing to do with any things we're talking about, that makes it so that people can get fresh fruits and vegetables. And we all know that, but we're not talking about that tonight. I don't think.
Hi, Jessica Stens. I'm a practicing physician for the last 15 years and now working a little bit more behind the scenes on population health management with Health Med. And along the lines of what this young lady here said about giving people a chance to actually participate in their own health and to follow the things that we already know about. And when we look at our healthcare system, we're 17% of the GDP, more or less. In every health organization we look at, they've barely gotten soda out of their institutions. People are working long hours. If we can't even do it for ourselves, how do we expect other industries to really follow suit and set people up for really healthy lives? Because it comes at a cost. how do we really get organizations to do that and to support it. And if you look at the literature that's out there for treating various conditions, we know what we should be doing. It's actually deploying it. And the stuff that we don't know, the incentives for publication, it doesn't necessarily line up with what we really need to know. It's what's flashy for the journals, right? The publication bias stuff that we all learn in our public health classes. So getting the ego out of medicine and our industries, and really where the rubber meets the road, supporting those things, not just the academics who know they can read it, but everyday people. I mean, that's where I think the action is.
All right. Any additional questions? Does anyone on the panel want to respond or no?
I think we all agree.
Okay.
I think that's why you're not hearing from us.
Did my
I
doctor
couldn't agree
talk
more.
to you?
All right, so we have a question in the fourth row.
My name's Tom Doherty from Healthcare Innovators. One of the questions I have is a lot of the technology to enable people to take better care of their health. Is there a technology that you find works better for the safety net population? Because 5 most important numbers in anyone's life are their zip code, and that determines their health more than anything. So is there, from your experience, something that moves that needle? Because that's the hardest one to bend.
I guess I can answer this one first. I think whether you are part of a low-income population or not, there needs to be a balance in the way that you receive support, both in person and sometimes using technology. A simple telephone works really quite well. There's been great studies that have looked at the use of groups not a cell phone even, just whatever phone the person happens to have, and you talk to them. It's a very simple technology. I think, however, the question you're really asking is what are some of the more modern communication technologies that could be useful. And it's not surprising that we all know that cell phones are nearly ubiquitous, that the increasing number of low-income individuals have cell phones that are smartphones. They may or not be able to afford all of the fancy elements to it, but they are. And if you look at text messaging as a structured way of giving people reminders, giving them information, giving them support, having them have the ability to communicate with others, to send in their information and the like, that can certainly make a huge difference. I think, however, the bigger question is, are we going to have we will always have a digital divide, and I'm afraid that that's true of almost everything in America, where we have the haves and have-nots. They'll have a digital divide, we'll have a housing divide, a food divide, early childhood development, a support divide. I think those, unfortunately, are here and very difficult to overcome. However, that being said, increasingly low-income populations are having access to web-based programming, to internet, PC-based programs, whether in their community or in their own homes. So I do imagine that still will make a huge difference. It just will be not quite as dramatic as it is in the more wealthy population.
Yeah, I guess my thought is that in the old days, geography was sort of destiny, because it was really difficult if you were in a certain area to actually get information, find out about doing things differently. And I think that with the information age that we are in now, it's much more accessible to know what you should be doing, what you currently don't have, how to potentially advocate for that. But I do think that even though all that information exists, to effectively create culture change for the safety net population so that they will engage in healthier behaviors is still something that comes down to motivation and making sure that that is something that we focus on, to make sure that those populations have more readily available the types of things to keep themselves healthy, whether it's knowing that they are in a food desert and they have to have better food choices, that it's okay not to smoke because everybody around you smokes. I mean, we see all those types of bad behaviors happen, but I think that we need to find better ways to reach out to those populations so that they will engage in healthier populations, because you can still be healthy and not necessarily be wealthy. But we find that at least for our populations that are in lower socioeconomic areas, that they're also engaging in relatively unhealthy behaviors.
And if we were to think about some of the again, sort of a mix of technology we already had and making it more accessible, and I think this is really something the ACA has pushed well. Some very specific examples. A lot of the things that we think of as the most dire consequences related to diabetes, blindness, kidney failure, and amputation, there are drugs that decrease the likelihood of those things dramatically, but we had large chunks of the population that didn't have good coverage for drugs or any until after the blindness, the amputation, the kidney failure. The fact that those folks now, through the ACA, are frequently, they have some sort of coverage. The fact that the electronic health records is giving their providers some sort of idea of whether they are compliant with the technology that is the drug itself. That's also something that is coming forward, that we could see some pretty dramatic results in some of the most vulnerable populations. Although we are kind of back to the game of how well can we engage those folks? How troubled are their lives? There's going to be some of them that will always have great difficulty taking control over their own health, as we're saying. But if we could change it on the margins, that would literally be legs saved. That would be dramatic and impressive. And I think that the changes in the technology that will better enable us to use the technology we already have, the creations of systems that allow providers to kind of know what's going on, even if it's only measuring how often that bottle was refilled, and to do it consistently and to have years of information on someone would be wildly helpful. And I think that when we're talking about some of the most vulnerable, there are pieces of the puzzle that have already been provided to the least vulnerable, and we've had remarkable results. I think we are, and I would say the ACA has done a lot for this. We are now in a world where we may be able to provide some of those base pieces to more people.
So the one other thing I would also add is that there's all this information that we could potentially get to help people. As the provider on the other end of the stick, there is this information overload. I cannot handle all the information that is coming to me. And I think that is also something, as we think about the next generation of systems, we need to find ways so that we can parse out the most important information. When I've done remote patient monitoring type of studies, or actually, let me just give an example of the engineer who shows up into my office who has hypertension. I get 12 measurements daily, that's in an Excel spreadsheet. That I don't need that level of information to manage your hypertension. On the other hand, the patient who doesn't show up in my clinic doesn't send me anything, and then of course their blood pressures are through the roof. So I think that managing the information that we're getting in a way that will lead to appropriate health change is, I think, what we really need. And as we have all these different technologies available to us that can provide us all this wonderful information, we need to figure out ways to really sift through that information so that we can deliver the best kind of health possible.
And I want to sort of give a bit of philosophy that's got nothing to do with technology. And I think collectively some of us have a failure of low expectation that becomes self-fulfilling. And the way to get around that, I believe, is to really think about not only what the barriers are and all the negatives, but what are the strengths and positives. Just like with a young child, you try to work at their strengths to help them to learn if they have learning disabilities. But one of the ways to think about is a technique called positive deviance. It basically says that there are individuals who have no special circumstances but do well when everyone around them, or most people around them, don't do well. And it's the village in Vietnam where the one out of 10 children are well-nourished, but they're no wealthier and no different than everybody else. And it turns out that they're well-nourished because their mothers are positive deviants who violate social norms by feeding their kids 3 times a day instead of twice a day, by adding green leafy vegetables and krill from the rice paddies, and by forcing them to finish their bowl of rice each time they eat. None of which was the standard in Vietnam, let's say. And then they then took those positive deviants and spread it throughout the community, came back 5 years later, and everybody was well-nourished. So it wasn't the technology that solved the problem. It was a different way of thinking and a different way of augmenting, of enhancing, of increasing the capacity of those individuals to do well.
So I wanted to follow up on that thought and kind of integrate it with some of the concerns we heard about the system we're working within. So I'm coming from a state in Maryland where we have global capitation for hospitals. All payers are getting the same rate, and they're now the hospitals themselves are accepting risk. It seems that could provide some incentive to invest in things like education and housing and community benefits that could overcome some of these social determinants that lead to health disparities. So are there any promising payment models out there that you think could address those core issues while also incentivizing the adoption of useful technologies and innovation in a way that improves the system, or is it still a very difficult game to play, I suppose?
I did hear about something recently that I thought was interesting. It was one of the, and again, this is bearing risk. It's an agency that works with one of the Medicaids in Oregon, that because it has real-time information on seeing their client appear in the emergency room, they have adapted a series of data analysts who are doing social workers being sent. That looks odd. Why is that person appearing twice in this short period of time? And having people who can literally follow that person back into the home and see what is going on there. And I thought that was an interesting model for an entity that is bearing the risk, at least trying to know what are the social determinants of health in that person's life, and hopefully being able to address some of them in that space. And it's, as you said, it's tech and it's risk that are motivating that form.
I think a natural conclusion, though it may never get there, of taking risk is that those risk-bearing, let's say, provider groups, by the way, providers and plans are all the same now. Everybody has one or the other, and it's hard to tell one from the other. But those provider plan conglomerates taking risk will quickly realize that the social determinants of health are where they can save the most money over what we imagine would be a relatively finite period of time. And whether they'll ever get to the point of actually paying for housing, they certainly could get to the point of helping to provide legal counsel so people can have adequate housing and help provide other things that were never considered part of what would be in healthcare. Whether that will ever get there or not, I don't know. But Maryland, I'm putting out hope that they may get closer to it because of the unified system of payment.
Yeah, I think that, we've talked a lot about culture in terms of, individuals and how they might change their behaviors. On the provider end, there's also a lot of path dependency, a lot of cultures in terms of the way that we do things, and we do things because this is the way that it's always been done. And I think that it will take some time it's for those changes to actually occur. But I think that, as you take on those risks, you start looking for those innovative ways. So while it may not show up immediately, I would expect that down the road, you will see organizations start implementing newer ways of delivering care that reach out into the community to start working on those social determinants of health.
Thank you. I think we had a question up here. Yeah. Yingy? We have a microphone.
Yeah, I'm Yingy from UCLA Center for Alzheimer's Research. I have a question regarding acceptance level of technology from provider as well as the patient. So, for instance, if we say Telehealth will be implemented tomorrow, and what percentage of patient or the provider will do that?
So I can at least speak from the provider end. Probably about 20 years ago when we first started implementing electronic health records, there were revolts. I think there's a well-known example here in the city of Los Angeles about a healthcare system that had a provider revolt on their hands. And so I do think that these days people are much more accepting of the technology because they're using it in their everyday lives. So I think that it would depend on how it's used and also how people receive, their compensation for how they use it. So a lot of adoption, at least we see from the provider end, is sort of held back because it doesn't really fit in with the current reimbursement models. On the patient end, when in our remote patient monitoring study, there were some 90-year-olds that were very compliant with using digital technologies. On the other hand, there were 50-year-olds, that we would have thought, should have been more compliant just because we would normally have this age bias, that older individuals might not use technology. And if anything, I think most of the studies, at least for remote patient monitoring for heart failure, would suggest that younger individuals don't do so well. And it's probably because those younger individuals who ended up having these bad conditions have a lot of other problems that hinder their technology adoption. So I think that the biggest thing comes down to, again, finding what's going to work best for different groups of the population. I would expect that over time, as everybody gets increasingly comfortable with technology, they'll be fine in terms of using it. It's just while we're in this transition phase where there are people who grew up in periods of time when we were still using cashiers that are not going to be as comfortable.
I think the way I'd answer that is to go back to the diffusion of innovation science. Everett Rogers was the leader of that, died maybe eight years ago, I guess, 10 years perhaps. A book called Diffusion of Innovation, which looks at the diffusion curve and the characteristic of the innovation, as well as the characteristics of the people who are looking at it. And almost all of them start out with the sort of quirky or early adopters who are, no matter what the technology is, and that they spread it to some of their associates, but still very, very small percent of the population. And then all of a sudden it gets into a little bit more into the normal people, so to speak, ones who are not dedicated and passionate about the issue. And then it goes up in a very rapid curve over a very short period of time and then levels off because you've gotten everybody there. Each one of those diffusion of innovation curves are quite different. If you think about online banking, or if you think about ATM banking, or fax machines. I remember the first fax machine I got, I had no idea what to do with it because no one had a fax number. And about a month later, I was sitting at a meeting, there were 5 of us, we were on a telephone, and the person hadn't gotten the mail that sent him a hard copy of the thing. I said, what are we going to do? It's a waste. And honestly, got all 5 of us sat there saying, what can we do? And finally, I said, we could just fax it to him. We go, oh, yeah. So by then, I realized it made sense. And then now it's obsolete, but it basically spread. So the answer is, it depends on the innovation. It depends on the quality of the innovation, how triable it is, how much benefit you can see from it, where it's been centered, who are the people that it talks to. So the answer is, it depends.
John, did you have a comment?
And there's always slow. I mean, actually this year we finally convinced the health committee of the California legislature to quit faxing us. Progress, technology.
They're called laggards, I think is the term for it.
Just a quick follow-up on that one.
Sure.
Take something like secure messaging. So I was at HHS, for the very first version of the Office of National Coordinator back in 2005. Secure messaging has been around since the 2000s. And yet there's still companies today that are coming out and say, oh, we're going to do secure messaging in healthcare. So that's really basic, and it's been almost 18 years now. So what is it that's preventing something that's so simple and yet so sensible as that from really having a broad impact?
Secure message meaning physician-patient communication through HIPAA compliant.
Physician or physician-patient,
Right.
either through
HIPAA compliant,
email or through encrypted text, or some combination.
I think it kind of comes down to making sure that it's integrated into the workflow so that it's behind the scenes. If you're going to require that I have to think about doing a secure message, or my patient is going to have to think about doing the secure message, they never do that. My patients just indiscriminately email me, and that's fine. I just tell them, if you're going to do that, you just got to know that your stuff is going to show up on the internet at some point. We can't be totally secure about it. But if we can get you to adopt the secure approaches and make it easy for you, which patient portals are increasingly getting easier, but they're not exactly there. Then it might work out better. I think that the best kind of technologies are the ones that allow you to interface however you want. You want to send me email, you want to text me, you want to securely message me through the patient portal. It doesn't matter. It's all going to get the same way in a secure way. That would be ideal. So it's got to be stuff that is behind the scenes, letting people interface however they want it.
As a follow-up to that, I heard some of the Kaiser leaders say reduction in office visits. They
Well, I think
did emails on top of all the office visits that they were already doing.
Well, so there's a study in Health Affairs by Dr. Pearl at Kaiser. I think they implemented in 2008, and they showed that office visits, I believe the office visits actually decreased over time by 2013, but the share of email, telehealth, and video exceeded office visits. So you do end up with this additive effect. So we end up with more net visits over time. But I think in the Kaiser study, after 5 years, you started seeing this tailing off of office where they were actually replacing in-person office visits with video conferencing or telehealth, but maybe not something like email because it is so short and difficult to. Right. Well, right. So, and the Kaiser model, it's free. So if you look at, John's very familiar. There's a bill in the legislature this year, AB 2507, which was a telehealth bill that focused on allowing physicians to bill the equivalent of in-person visits for telehealth, video conferencing, store and forward, and text and email. I think the idea would be you end up with some sort of constraint of use because of the fact that people are now, they're used to calling their doctor and kind of getting free help for 2 or 3 minutes, and now they're going to be billed for the visit potentially. And so there would be a patient adoption issue. At the same time, there's a physician adoption issue that I think we would probably have to struggle with. So I think we have time for one last question from Stephen.
Hi, my name is Steve Lee. I'm an alum of the MPH program. So I have a question. So one potential barrier to the adoption of technology and innovation is being able to demonstrate value at the customer level. So I was wondering if you could talk a little bit about your experience in leveraging data analytics and specific KPIs and metrics to build a concrete enough analysis to justify, say, additional funding or investment in telehealth at UCLA Health, or to convince a potential customer, Canary Health, that they should be adopting your product past just the proof of concept.
Yeah, very complicated question. But the fundamental approach is you identify programs that have proven effective in person. So you've got a long-term research base of what we know works with individuals. So the Diabetes Prevention Program, the Stanford Chronic Disease Self-Management Program are 2 examples. And then what you have to do is demonstrate that your program has equivalent fidelity to the original model, similar degree of engagement, and similar degree of sometimes easier to measure outcomes, not necessarily as sophisticated as the entire original study. And it's not hard to imagine that if you say, listen, when it costs X dollars with this much integration, with this much challenges with lots of people and logistical challenges, and it costs 50% of X with less administrative, if I get the same results at half the cost, even if I get half the results at half the cost, won't you be happy with me? And the answer is usually yes. So when you start out with the proper evidence to begin with and then extend it into the technology, that's one part. The other is you've got to do your own studies. You have to do studies with that program. And it turns out that the question you didn't ask, but what you should, is it's not how do people do after they show up. It's what does it cost to get people to be activated, engaged, sign up and show up, and then do well. Because all of the programs that you base things on are based on scientific randomized whatever controlled trials post-show up. And in the modern world, that's not enough. You really have to demonstrate that you have the capacity to get people to actually sign up and show up and then complete the program at a high enough rate.
Yeah, I think that at the end of the day, we show value when the patient actually gets something out of it. And again, in terms of using these type of technologies, if it's going to enable the patient to get the kind of care that they need, these type of technologies will be valuable. And that's the reason why we have been pushing forward with the adoption of these technologies. The other thing I would say kind of gets back to the issue about email communication. Ultimately, email itself is something that I do a lot in my clinic, but probably the biggest thing is actually making sure that you educate your patients appropriately. So basically, none of my primary care patients will contact me for antibiotics until after 2 weeks. And that, if we think about the typical type of urgent care thing that we see, people come in and say, doctor, I've been sick for 3 days, I'd like some antibiotics. And, we know that, study after study suggests that we've been inappropriately prescribing antibiotics in those type of situations. So ultimately, if we are able to educate patients, which, again, gets back to the empowerment of the patient in terms of the knowledge that they need to be healthy, they'll do the right things. But we need to be able to provide that in a way that's going to be accessible for them, in a way that they will trust. And that's still something that, even though Dr. Google has been out there, I get a lot of questions from Dr. Google when my patients come in. We need to make sure that they are going to use information appropriately in a way that's going to be personalized for them.
I would think, too, that part of the some recognition that evidence alone does not make things happen, and that a lot of what we do is not evidence-based, and that is going to continue as we go forward. And some of the things we're talking about with the adoption of technology, it is not going to be evidence that drives it. It's going to be the existence of the systems and their utility and people's familiarity with it. And a lot of it seems reasonable will probably push things a good ways forward. What I presented today was, it's newish technology. It's actually quite common already. And at some point, we will have evidence as to whether or not it does something or not. I think that's going to be, though, especially when we're talking about these complex health issues, it's years and years before the data is even out there to begin trying to pull it. So it's going to be interesting to see how these things walk and see if we can learn to walk things back that don't seem to be doing what we hoped that they would do. And I think that is going to be a huge challenge as we go forward in a not infinite resources universe.
Well, let's take some time to thank our panel. I also wanted to thank Esther Siak and Eric Wilkes from the School of Public Health for coordinating this entire year. And stay tuned for the fall, because there will be an exciting new year of Paul Torrens Health Forums at UCLA starting in September. So thanks everyone for coming, and have a great summer.